Well, we will move to the last lecture in this day, which is our colleagues from Israel and a very friend of mine, Dr. Carlos Gordon. Let me tell you something about Carlos. Carlos is Argentinian. He was born in Mendoza, the wine country of Argentina. He moved as a young medical doctor to Israel. He's working in Tel Aviv University. He had a big experience with SCA and bilateral vestibular failure. Good night or good evening. How are you?
Thank you. Very good. I'm happy to be with you. Can you hear me? Yeah?
Yes.
And are you seeing my presentation?
Now you can share your screen.
You're seeing my presentation?
No, only you.
No?
Not yet, not yet.
Not yet. Just a minute.
Sharing a screen o
Yes.
compartir pantalla. I have some questions.
You are seeing now? I'm pressing share screen.
You will have to click on the green share screen button once.
Yes. Yes. I'm pressing.
Then you have to select your slide and then again say share.
Yes.
Yes, yes.
Now are you seeing it?
Yes.
Yes?
Yeah.
Ah, okay.
You can go full screen now.
Yeah.
Now you have to open the PowerPoint.
Yeah, no. It's okay now?
Perfect.
Okay.
Yes.
Well, so very happy to be with you. I'm hopefully next time personally all together in Madrid or everywhere. Okay. I will talk about oscillopsia in bilateral vestibular failure, the enigmatic symptoms. This is me, and those are my colleagues and collaborators. And we will use the term adopted by the Barani Society, the bilateral vestibulopathy, that is the same meaning of other terms, bilateral vestibular hypofunction, hyporeflexia or areflexia, bilateral vestibular failure, deficiency, weakness, or loss. And in fact, we're talking about a chronic vestibular syndrome characterized by unsteadiness when walking or standing, which worsen in darkness or on uneven ground or during head motion. In addition, this patient may describe head or body movement-induced blurred vision or oscillopsia, and there are no symptoms while sitting or lying down under static conditions. The diagnosis of bilateral vestibulopathy requires bilaterally significantly impaired or absent function of the vestibular ocular reflex, VOR. And what about the etiology? The majority of cases, about 50% of the cases, are of unknown etiology or idiopathic. The second place is in aminoglycosid autotoxicity, mainly gentamicin. There are cases after vestibular neuritis or Meniere disease, but are other rare causes like cerebellar disorders with vestibulopathy And I marked this the spinocerebellar ataxia or Machado-Joseph disease because I will show you some data of these patients with bilateral vestibulopathy. In fact, this is a relatively rare condition. The prevalence varies between 30 to 80 patients or cases in 100,000 adults. This is probably an underestimation of the accurate prevalence because bilateral vestibulopathy is often missed or misdiagnosed because of its unspecific symptoms, the insidious onset and slow progression of many cases. And for this reason, in many cases, it is overlooked or only diagnosed after a long delay. And here I am presenting you an easy case of bilateral vestibulopathy, a 60-year-old man with dizziness, unsteadiness, and jumping visual world when walking. It appears following lumbar spine surgery complicated with osteomyelitis and intravenous antibiotic treatment with gentamicin. And on bed examination, he has bilateral positive head impulse test. And here you can see the video head impulse test with almost or totally or absent function, the VOR, horizontal VOR, with some function of the other canals, but really a very, very severe case of bilateral vestibulopathy in a patient that was complaining also with, on oscillopsia. But this is, I will present a missed case. This is a 53 years old man that I saw 23 or 24 years ago with 2 years of unsteadiness, dizziness that was worsened with head movements. There was no vertigo, no history of vertigo, no oscillopsia, no any complaint on oscillopsia. The formal neurological examination was totally, and the neurological, extensive neurological workup was totally normal. And now you can see what happened with the head impulse test. That is clearly positive or pathologic on both sides. And this you can see the rhomber sign is absent. And when he's walking with eyes closed, is very cautious. But this is all the formal neurological examination was normal. But so, sorry, what was missing in this clinical evaluation was the head impulse test that was positive. The treatment for this patient is vestibular rehabilitation, but the best treatment for him, in fact, was paddleball game at beach. So the first take-home message is the bedside head impulse test is mandatory in every case of chronic complaints of unsteadiness or dizziness, even if the patient is not complaining on oscillopsia. And this is another missed case of a 75-year-old woman with 1 year dizziness and unsteadiness following a mild upper respiratory infection with fever. There was no vertigo and no any complaint of oscillopsia. She's still very active and working even in an infant daycare. And the suspected diagnosis was dizziness or disequilibrium of the elderly. But when she came to our clinic in the neurological examination, on the bedside examination of the head impulse, it was very, very pathological. And you can see here the result of the video head input test. That is a total absent, almost absent in the horizontal, and some activities in the other canals. So, and I am giving this case because it's an older lady. And in fact, in this paper from 1993, from the group of Bob Ballo, they describe disequilibrium of unknown cause in older people that, in fact, they describe that in all of them, the Romberg test or the Romberg sign was absent. But when doing a vestibular test, they found a considerable number of patients with bilateral vestibulopathy. We are not talking about vestibulopathy, that it's another, or this is also comprehend the disequilibrium or unsteadiness in older people, but we are talking about bilateral or significantly loss of the VOR. The VOR must be less than 0.5. The gain of the VOR, horizontal VOR in these cases, must to be less than 0.6 for the horizontal canal. So the take-home message is in chronic bilateral vestibulopathy, Romberg sign is absent in formal neurological examination, but we know that could be positive when standing on foam. And so what about oscillopsia? I am taking this from the main papers, that bilateral vestibular weakness almost invariably produce the symptoms of oscillopsia in a paper of Timothy Hain 2 years ago. But in the literature of Michael Stroop and his group, a minority of patients, about 40% of this patient, also have movement-induced oscillopsia, in particular while walking. So you saw this patient without oscillopsia, but with a significantly bilateral vestibulopathy. So bilateral vestibulopathy does not necessarily cause oscillopsia. And so the classical explanation for oscillopsia is that in bilateral vestibulopathy, during rapid head movements, the VOR cannot maintain the eyes stable in space. And thus, the image of the retina suffers from retinal sleep, which is experienced as an illusion of an unstable or jumpy visual world that is in fact oscillopsia. And this is a very disabling phenomenon. People cannot read when walking and are very, very disabled in any activities when they are moving the head. And the mechanism is not completely clear, in fact. So you saw these examples of the VHAT, and we ask why patients with a similar and very significant bilateral vestibular deficit do not complain on oscillopsia. So we carried out a study to evaluate the relationship between the vestibular impairment, saccade eye movements, balance and spatial orientation function, and the complaint of oscillopsia in patients with long-lasting bilateral vestibulopathy. And we checked we examine 15 chronic peripheral bilateral vestibular vestibulopathy, 11 idiopathics and 4 from ototoxicity, 17 central bilateral vestibulopathy. Those are patients with SCA3 or Machado-Joseph disease that we assume that they have central degeneration of the superior or the caudal part of and the medial part of the vestibular nuclei, and 22 healthy controls. They underwent all the detailed neurological examination and a comprehensive laboratory vestibular, saccade test, balance, and spatial orientation evaluation. And here you can see a patient, a 72 years woman with a SCA3 and bilateral vestibulopathy. You can see that she has also saccadic smooth pursuit, gaze evoked nystagmus. She has no any vertigo and no any complaint of oscillopsia. The saccades are also slow. And now you will see, you will appreciate the head impulse test that is very deficient bilaterally. No oscillopsia, no any oscillopsia in this patient. Wait, sorry. And here you see the VHIT of this patient, this Machado-Joseph disease patient in comparison with a healthy control of the same age. You can see all these gains are almost 1, and here an absence of response in almost all canals. And the main, just I will summarize the main results. You can see here the VOR gain on the VHIT for all canals, the lateral canals, the anterior and the posterior, in the controls, MJD patients, and the bilateral, peripheral bilateral vestibulopathy. That also Machado-Joseph and bilateral vestibulopathy have significantly lower gains. And also the SHIMP, the suppression head impulse test of the on lateral canals, evaluating the remaining activity of the VOR, is also impaired in the patients with bilateral vestibulopathy. But concerning oscillopsia, in fact, we have, from the 15 patients, we have only 5 peripheral bilateral vestibulopathy patients, but non-Machado-Joseph disease complaining about oscillopsia. And all the VOR measurement of these peripheral patients with and without oscillopsia were very similar, including asymmetry between the ears and even some difference between the canals of the same ears. We couldn't find any measure on the VOR that could differentiate a patient with oscillopsia and patient without oscillopsia. And here you can see 2 results of the VHIT in a patient with oscillopsia and without oscillopsia that are very similar. On the other hand, and not surprisingly, the dynamic visual acuity test was significantly worse in patients with oscillopsia. They lost at least between 4 and 5 lines when shaking the head, and patients with oscillopsia also they lost only 2 to 3 lines. And this is an interesting, really interesting finding. So because the saccade latency of the patient with oscillopsia was in the normal range, and the patient without oscillopsia has some prolonged latency. What about spatial orientation? This is the triangle completion task. In this task, the subject stands here, and the experimenter leads the blindfolded subject from a starting point, this starting point, on a path consisting of 2 sides of the triangle, and then from this stopping point, the patient blindfolded is asked to complete the triangle to go to the original point, and we can measure the angle error and the distance error. And here, the patient with a difference between the patient with oscillopsia and no oscillopsia. Patient with oscillopsia, very interesting, perform these 2 tests better than the patient without oscillopsia. So I would like to summarize the main results, saying that only 5 of the peripheral bilateral vestibulopathy, but non-Machado-Joseph disease patients complained about oscillopsia. All VR measures of the peripheral vestibular patients with and without oscillopsia were very similar, and subjects with oscillopsia had significantly worse dynamic visual acuity test than those without oscillopsia. Interestingly, the saccade latency was normal in oscillopsia patients, but significantly prolonged in patients without oscillopsia. And doing a receiver operating characteristic analysis showed that the saccade latency to be is an excellent classifier between oscillopsia and non-oscillopsia, with an area under the curve of 0.95. What about the balance that I didn't show, but the balance evaluated by computerized posturography was impaired in all the peripheral bilateral vestibulopathy, but without any difference between oscillopsia and non-oscillopsia patients. In the spatial orientation test, the triangle completion task that measure path integration and navigation, oscillopsia patients demonstrate significantly less distance and deviation errors compared to non-oscillopsia patients. And our conclusions are the oscillopsia, in fact, was present in only 33 of our patients with peripheral bilateral vestibulopathy, but not in central bilateral vestibulopathy. And its appearance is not associated with the degree of VR impairment. The normal saccade latency and lesser error in path integration and navigation in patients with oscillopsia can be explained by different strategies of central compensation, but the reason of oscillopsia appearance is still enigmatic. And just to come back to the take-home messages, when you suspect bilateral vestibular failure, the bedside head impulse test is mandatory in every case of chronic complaints of unsteadiness or dizziness. In chronic bilateral vestibulopathy, Romberg sign is absent in formal neurological examination, but probably not when standing on phone. I suggest to try to test dynamic visual acuity because it is for sure deficient in bilateral vestibulopathy. Bilateral vestibulopathy does not necessarily cause oscillopsia. This is very important to the clinician. And the reason of oscillopsia appearance in bilateral vestibulopathy is still enigmatic. So that is, thank you very much for your attention.
Thank you very much, Carlos. I don't see any additional questions. Jorge.
Yeah, Carlos, that was great. Thank you so much. I have a question. So did I understand correctly that prolonged saccade latency was associated with no oscillopsia? Is that correct?
The prolonged latency is in patient without oscillopsia.
All right.
Yes,
So,
patients with oscillopsia have almost normal, the saccade latency is in the normal range. Yes.
And this saccade, we're talking about the saccade in response to visual targets.
Yes, yes, yes. And without any head movement.
Exactly.
Yes.
So it sort of makes sense, right? I mean, they have learned that if they take a little time to generate the movement, then they might have a better fixation when they go to catch the target, right? Is that the thought?
Yes, I am not sure really. The explanation we are thinking about really a good explanation because intuitively I suspected that they will have an impaired, probably a prolonged saccade. But in fact, if you think about patients without oscillopsia, those patients probably have making the prolonged saccade to really prevent oscillopsia. But in fact, this is the most, I think, the most interesting and amazing finding, and the problem that it's the limitation of this study is that we have only 5 patients with oscillopsia. In fact, we were surprised that the other patient do not complain on oscillopsia, and the saccades, we know that the saccades is one of the mechanisms used for compensation or substitution of the vestibular loss, but the exact explanation why is this difference, we have not an exactly hypothesis. We are trying to make a good explanation of this.
There is a question. Can you read the chat, Carlos?
Yes, just a minute. Yes, what in this?
Last question.
A confusion because
in this case, if there is a
bilateral vestibular loss.
Yes, is probably to obtain deficient realization.
An optokinetic movement. I think that the confusion is because you show those alteration in SCA patients, but it's a totally peripheral cases.
Sure. Yeah, the patients with the peripheral bilateral vestibular loss has no any problem with smooth pursuit and not on optokinetic. They have no gaze-evoked nystagmus. The patient that I saw The last patient that I saw is a patient with a SCA3 or spinocerebellar ataxia type 3 with a profound bilateral vestibular loss that we suggest that is from central degeneration of the vestibular nuclei.
So going back, sorry.
One more question. They all had, the ones with the prolonged latency, did they have covert saccades or overt saccades when they did it?
A good question. We look at this, but no, we couldn't differentiate. We look at this because there is some differentiation, or there are some papers or reports that are different in the covert and the overt saccades, but no, we couldn't find any difference in the overt and covert saccades. In the VHIT, we couldn't see any difference, and we look for some explanation, and we couldn't find. No, thank you for this question.
So I have two questions are linked. So the people that you studied, they were all sorry if I missed that part. How many of them peripheral versus central?
Peripheral were 15.
Like how many of them had like more cerebellar damage, so to speak, or?
No. There were 15 from peripheral source, and 17 patient with Machado Joseph with a SCA3.
And anybody, and was there a difference in the saccade latency in the two? So I would assume that MJD would have more saccade latency problems, right?
Yes, but again, we for sure, MJD have more prolonged latency, also less accuracy. But what I present here was the difference between the saccades only in the Oscillopsia patient. This we were here interested to show the difference between the patient with and without Oscillopsia.
Yeah, no, but the reason why I'm asking that question is because, again, going back to original question that Jorge has about the mechanistic underpinnings, and that's something that you are still working around, right? So one thought could be that those who did not have Oscillopsia, and surprisingly, they had higher latency, in those people, their brain somehow develops a mechanism to sort of interpolate the signal. So interpolate the visual signal. So now like they have like one image and the other image, and then the saccade is not made, and brain learns that there is an adaptive mechanism that it learns to kind of fuse the two images to come up with more of a continuum. And now you throw in a saccade in between, then that whole learning, that whole adaptation is lost, and then they get Oscillopsia, right? So my question is like, if we can figure out whether the differences in different lesion and whether they can parse out having more propensity to develop Oscillopsia versus not, or somehow if we can test that idea.
Yeah, sure. This is very, very interesting, but in Machado Joseph, there are we found also patients with normal latency and patients with prolonged latency. None of these patients have Oscillopsia. I assume that also, listen, the Machado Joseph, the degeneration is so slow that probably the brain have the opportunity to make a compensation, at least for Oscillopsia, not for ataxia. Those patients have, in fact, not only cerebellar ataxia, but also vestibular ataxia. And the saccades, also the velocity of the saccades in patients, if you took all the saccade velocity of the patient, it looks for the Machado Joseph looks normal, because they are patients with very low velocity and saccade velocity, and there are patients with really very good and very fast velocity. So I don't know if we can really make really a conclusion what is going from the point of view or from the way of the analyzing the saccades in Machado Joseph and comparing with the bilateral peripheral vestibulopathy. But we are in the process of trying to understand and to collect more and more data.
Yeah, and I'm wondering the slowness. So the one thing that very interesting thing that you brought up was like gradually getting worsening process versus acutely worsening process, and having brain enough time to develop compensation versus on the other side not. So in that case, the good model for peripheral could be schwannomas, right? Like in the schwannomas, they have like slowly growing mass. So the whole deficit happens slowly. But over there, unlike Machado Joseph, they don't have cerebellar, or in Machado Joseph, it's also midbrain, right? So they don't have that deficit.
Yes.
So it will be interesting to compare like these different classes and how the oscillopsia appears in them.
Yeah, we need to collect patients with neurofibromatosis too, with bilateral schwannoma, but those are very, very, very rare. So,
I know, yeah.
One practical, excuse me, one practical point is that probably oscillopsia is caused by more acute vestibular bilateral failure. You know, it's a lot of common when you see patients, at least in our country, it still is common to use gentamicin for severe infections. And at least at the beginning, oscillopsia is always the rule. All the patient has oscillopsia with ataxia. You know? But are acute cases, you know, sudden loss of bilateral function.
Okay, Sergio, I agree with you. I suppose that the patients with gentamicin, that they have acute onset, because all the other patients without ototoxicity, we don't know when it appears. All these patients for sure were really chronic. The diagnosis was performed at least 9 months before our examination, even with the patient with ototoxicity, because you know that there are patients with gentamicin ototoxicity that recover. But from these 4 patients and from other patients with ototoxicity that recover, not all the patients, I believe that at least two of these patients complain on oscillopsia. So I believe that the patient that developed the vestibular loss very rapid have more oscillopsia than those that develop slowly or slowly progressive. So I don't know, I have no a clear answer, but yes, we believe that when the and the problem is also the literature is not clear. When you see and you look at the articles, so you see that in fact almost all the papers are based on the chronic vestibular chronic bilateral vestibulopathy. There are not mentioned cases of acute. I think that only the recent paper of Angel Batuecas in Frontiers that also refer that also try to explain oscillopsia by some mechanism of saccades eye movements, refer that they differentiate patients with acute and chronic oscillopsia.
Okay. Well,
we did it.
Good job.
Okay.
Must be late. Must be like midnight in Israel, right?
I think that that in India, so everybody's sleeping there.
Yeah, in
Probably
Yeah.
Sugi will wake up in an hour. It's probably gonna be morning
I
soon.
have a bad case of insomnia.
I am also going to bed now.
Yeah, it must be
This
midnight
is
there, right?
11, almost, no, 11th and a quarter. Yes, 11:15.
Yeah.
So good night.
Good
Good
night.
night.
Okay.
Thank
Take
you very
care.
much.
Thank you.
And
Yeah.
hopefully next time together, not in virtual.
Nos vemos
Bye.
mañana.
Yeah.
Sí. Ciao.
Thank
Sergio,
you.
I send you an email. When
Yes.
you do this, the Babinski sign, the design energy, do they lateralize?
No.
They don't. Because
No.
it would be nice to try to correlate with ocular lateral deviation prospectively. To see as they're trying to get up, they can do better one side than the other. Just think about it.
Okay.
Maybe we'll look at it.
I can check our data. Perhaps we had that information.
Yeah. All right. Sound good.
Very
Thank you.
nice.
I'll see you tomorrow.
Oh,
Yeah.
great. Yeah, it was
Jorge, will
fun.
you come tomorrow? I'll see you tomorrow
Yeah.
if you have time.
All right. Take
Yeah.
care.
Take
Bye.
care. Bye. Bye. Bye, Sergio. See you tomorrow. All right. Let's see.